Hey guys, so something I realized during my second year of medical school was that way too many students simply overlooked general pathology. Gen Path will be nearly 40% of your MBME final, so it should not be simply ignored. A very important topic to understand is wound healing and repair. Not only is this very commonly tested, but it also integrates many different components from the other classes you've taken, including the types of cells, cytokines, and structural components that all play a role. And these all can be tested on class exams, shelf exams, and step 1. So starting with tissue repair is necessary following any sort of trauma or inflammation. Inflammation is not only necessary to eliminate pathogens, but it can also serve as the transition from injury to the beginning of the repair process. Tissues can either be repaired by regeneration or replacement, and replacement meaning scar formation, or it can be a spectrum of both components, both regeneration and replacement working together. Regeneration is when a tissue can replace a damaged area and return to its normal functioning state, and it acts as its parent organ before the damage. Regeneration will occur after a mild injury, like a shallow cut through the skin, that does not damage the underlying tissue. Any uninjured cells that are able to divide, either labile or stable cells, replace the site of injury. Regeneration is common in labile tissues, like the skin epithelium, bone marrow, and the GI tract, and also it occurs in stable cell populations like the liver. Labile cells are constantly dividing. They have stem cells that are continuously turning over, like I said, in the skin, bone marrow, GI tract, whereas in contrast, stable cell lines have cells that are quiescent in the G0 phase, and those can return to active division when needed. The healed tissue looks like the original tissue and has complete normal function before the injury. In contrast, scar formation occurs when the cells cannot regenerate and necrotic tissue is replaced by a scar, or when the supporting structures of the tissue are damaged, since cells need a basement membrane to regenerate on. When the tissue cannot regenerate, a fibrous collagen scar is going to replace the damaged tissue, and obviously this collagen scar does not have the same function as the parent organ. For example, in a myocardial infarction where the cardiac myocytes are just replaced, the cardiac myocytes are permanent cells so they can't divide, and they're just replaced by a collagen scar. So while using this video, be sure to review your class notes over both cell proliferation, receptor signaling, etc., because you should be able to integrate those concepts with the concepts I'm about to present in wound healing. So regeneration of tissues occurs thanks to the proliferation of both residual cells and adult stem cell populations. It's tightly regulated by a number of growth factors and cytokines. Tissue repair is mediated by paracrine signaling via growth factors that can interact with their conjugate receptors. The injured tissues, vascular endothelial cells, meaning the endothelial cells lining blood vessels, and fibroblasts must all proliferate in order to maintain the normal cell population size. The normal cell population is normally in equilibrium when the cell death via apoptosis is in balance with both proliferation and differentiation of the cell pool. When there's tissue injury, we're going to have growth factors that increase the rate of stem cell proliferation to regenerate the cells that were lost in the injury. Stem cells have properties that are unique to them, which is both asymmetric differentiation and self-renewal. During asymmetric differentiation, the two daughter cells of the stem cell are not the same. One stem cell differentiates into a specific tissue type, while the second maintains the adult stem cell population. On their own, though, stem cells cannot regenerate tissue. Tissue repair depends on the integrity of the extracellular matrix that gives scaffolding for the tissue renewal. Additionally, the extracellular matrix controls cell proliferation and differentiation. Without the basement membrane intact, a wound or injury will heal by replacement with scar formation rather than regeneration. For example, the liver is very unique in the fact that it can regenerate greatly after surgical resection. This compensatory hyperplasia can only occur, though, if the connective tissue framework is intact. In contrast, if there's extensive infection or inflammation, like in severe alcoholism or hepatitis, that annihilates the connective tissue architecture, then there's very limited regeneration, and this results in a scar. And this is known as liver cirrhosis, of course, where the liver scars down and has no function. So looking at wound healing a little bit closer, let's talk about scar formation. In severe and more severe injuries, particularly where there's extracellular matrix destruction or there's injury to non-dividing cell populations like I mentioned with the heart, there is a replacement of the organ with scar tissue with or without some minor component of regeneration, and this can occur like re-epithelialization over the top of a scar. As a broad overview, the normal tissue gets injured First thing that happens is going to be hemostasis to prevent blood loss. Be sure to review those notes over hemostasis that were covered in class. Next, there's an inflammatory stage where there's recruitment of white blood cells that are attempting to rid the injury of any foreign material. The proliferative phase is going to begin within 1 day of that inflammatory stage. The proliferative phase then consists of angiogenesis, collagen deposition to form granulation tissue, and wound contraction. Angiogenesis is where you have new blood vessels growing into the area of injury. This blood supply allows the migration and proliferation of fibroblasts, which are going to deposit large amounts of collagen, forming granulation tissue. Fibroblasts are going to arrive within the first 24 hours, and by days 3 to 5 have developed granulation tissue. This granulation tissue is a very delicate type of tissue that typically is found underneath a scab. Histologically, if you look at granulation tissue, there's loose extracellular matrix, like collagen 3 with macrophages and fibroblasts. In granulation tissue, there's also very thin, fragile capillaries, so it's well vascularized. And there is also a special type of fibroblast known as a myofibroblast that acts in wound contraction. The fibroblasts continue to deposit collagen, and then in the final phase, the granulation tissue matures and is reorganized into a stable scar as collagen is converted to the stronger type 1 collagen. So looking at the 4 stages of wound healing, we have hemostasis, inflammation, then the proliferative phase, which I mentioned has angiogenesis, collagen deposition, granulation tissue formation, and wound contraction, followed by remodeling and maturation. So let's look a bit closer at the proliferative phase, starting with angiogenesis. Angiogenesis is the first step in the proliferative phase in the formation of granulation tissue. This is the formation of new vessels from existing primary vessels. Angiogenesis is the process of forming vascular sprouts that form these new vessels. This is especially important in tissue repair that forms a highway for nutrients and cellular infiltrate to the site of injury. Like in any form of injury, there's also an initial vasodilation during the inflammatory phase. Vasodilation is going to occur thanks to things like nitrous oxide and VEGF, vascular endothelial growth factor, that also increases permeability along with other inflammatory cytokines like TNF-alpha, histamines, etc. Next, the parasites surrounding the vessels separate and the endothelial cells are going to proliferate, producing the leading edge of endothelial cells that migrates towards the center of the injury. The endothelial cells are going to organize into capillaries and kind of roll up, and then the supporting structures are then recruited around them. Both parasites surround the endothelial cells in the capillaries, and vascular smooth muscle cells are going to surround the endothelium in the arterioles and venules on either side of the capillary beds. After the new vessels are formed, the signaling pathways for angiogenesis are shut off and angiogenesis is suppressed. The 2 key factors involved in angiogenesis are VEGF and basic FGF2, which is fibroblast growth factor. VEGF is commonly induced by hypoxia and the signaling of HIF1 alpha, which is hypoxia inducible factor 1, along with other stimulants like platelet-derived growth factor, TGF beta, and TGF alpha also. VEGF is a key contributor to angiogenesis of tumors also. You'll learn in pharmacology that bevacizumab is a monoclonal antibody that targets vascular endothelial growth factor, and this is used to prevent tumor blood supply. And that makes sense because that's one of the main factors for angiogenesis. The second key angiogenic factor is basic FGF2. FGF is going to induce proliferation of the endothelial cells, allowing new vessels to sprout from the primary vessels, and also it's going to recruit macrophages and fibroblasts to the site of repair. Now that there's blood supply to the wound, there can be recruitment of cells and nutrients. First, there's migration and proliferation of fibroblasts, followed by the deposition of extracellular matrix to form granulation tissue. The key cytokines involved are platelet-derived growth factor, FGF2, and TGF beta. These 3 cytokines are produced by inflammatory cells at the site of injury, like macrophages and other cells, and ultimately acts to recruit and activate fibroblasts. Over time, those fibroblasts slow their rate of proliferation, and angiogenesis also slows. The fibroblasts then switch from a dividing phenotype to more of a secretory phenotype that increases extracellular matrix production. So they initially proliferate, and then they start laying down the collagen. So as stated, the fibroblasts make collagen and extracellular matrix as early as day 3 to 5, but production can continue for many weeks. So you have a peaking pretty early on, but it will continue as the wound actually continues to mature. Initially, there's more collagen synthesis than there is degradation, leading to a net increase in extracellular matrix. Over time, though, collagen degradation is going to balance out with the rate of formation, so there's no net accumulation, it's just different types. So rather, extracellular matrix is going to mature, and the new vessels that were formed are going to regress as the scar is made into a stronger collagen. TGF-beta is a very potent inducer of extracellular matrix production, causing fibroblasts to lay down collagen, fibronectins, and proteoglycans. Uniquely, TGF-beta inhibits collagen breakdown by inhibiting proteinases and activating the TIMPs. TIMPs are the tissue inhibitors of metalloproteases. TGF-beta is anti-inflammatory, also like the cytokines, for example IL-10, so TGF-beta inhibits white blood cell production and proliferation. TGF-beta plays a crucial role in scar formation and fibrotic change in things like the lungs, the liver, and kidneys in times of chronic inflammation. So overall it acts to increase the amount of collagen in fibrous tissue. Additionally, FGF2 and platelet-derived growth factor play a role in extracellular matrix deposition. Platelet-derived growth factor is made by endothelial cells, macrophages, and smooth muscle, resulting in the migration and proliferation of fibroblasts and smooth muscle cells. Neither FGF2 nor PDGF inhibit collagen degradation like TGF-beta. So the next step is contraction. Wound contraction is a very important part of healing by secondary intention, whereas healing by primary intention has minimal or no wound contraction. I'll talk about primary versus secondary intention a little bit later. Within granulation tissue, there's a specialized type of fibroblast known as the myofibroblasts. Myofibroblasts have an intermediate phenotype, somewhere between a fibroblast and a smooth muscle cell. Myofibroblasts have both actin and myosin filaments allowing contraction. Wound contraction occurs as an active granulation tissue is being laid down and can contract a wound to 1/4 of its original size or even smaller in some cases. The function of wound contraction is to eliminate excess non-functioning fibrous scar. For example, in the heart, a ventricular wall is replaced by collagen, and so it will not have contractile abilities anymore, and without contraction would leave a large scar, and this would act as a kind of an outpouching that could be a nidus for a blood clot. Instead, the scar contracts and pulls together the functional myocardial walls, flanking the scar on either side, eliminating any organ dead space. So after granulation tissue is laid down, all those things that I've mentioned, we have maturation. So after the bulk of the extracellular matrix is formed, it must be remodeled into a stronger scar. Think of the initial synthetic period as kind of a band-aid that just holds the wound over until a stronger scar can be made. The key modulators in this remodeling process are the collagen degradation enzymes by the matrix metalloproteases. The matrix metalloproteases are zinc-dependent collagenases that are produced by many cells within granulation tissue, including fibroblasts, macrophages, and even neutrophils. And this explains why zinc deficiency can cause issues with wound healing. The matrix metalloproteases are secreted as zymogens and are then activated by proteases like plasmin. The TIMPs that I mentioned earlier, the tissue inhibitors of metalloproteases, act to inhibit matrix metalloproteases to avoid excess activity. The matrix metalloproteases actively remove amorphous collagen, fibronectin, and specifically type 3 collagen, and then there's remodeling of the scar to a stronger type 1 collagen. Type 3 collagen is much more pliable and loose, whereas in contrast type 1 collagen is much stronger and has higher tensile strength. Remember, type 1 collagen can also be found in the skin, bone, and tendons. So let's talk about some pathologies that can occur in wound healing. As with all physiological processes, there's different variables that can affect wound healing and that can cause it to be delayed or ineffective. So one of the most common causes of problems with wound healing is infection. Infection is a very common cause of delayed wound healing, and having an infection not only increases damage and inflammation, but it also increases the length of inflammation. So you have more inflammation for a longer time, and this delays the transition onto healing. And when we're talking about an infection, Staph aureus is the most common cause. Similarly, a foreign body can also impair healing. Malnutrition can also greatly hinder repair. For example, a general protein deficiency can affect many different steps in wound healing. Zinc deficiency can cause delay in wound healing due to loss of the critical enzymes like the matrix metalloproteases, which is a problem with maturation. Similarly, scurvy, which is lack of vitamin C, can cause poor collagen formation due to the lack of activity of prolyl and lysyl hydroxylases needed for collagen formation and the eventual cross-linking of collagen. Glucocorticoids like cortisol and hydrocortisone are also potent anti-inflammatory drugs, and these can cause problems with wound healing. A major side effect of steroids is poor wound healing since they inhibit TGF-beta production and collagen deposition, although this may be a therapeutic use of steroids since they decrease fibrosis and chronic inflammation. This inhibition of extracellular matrix deposition and remodeling is the same reason steroids can cause poor bone health when you're taking them chronically. Mechanical force is a pretty self-explanatory variable that can cause delayed wound healing. Any traction on the wound or pressure can cause a wound separation, and this is known as dehiscence, just causing it to pull apart. And then a final thing that can affect wound healing would be poor perfusion, which can delay wound healing. There is no delivery of nutrients, cells, or cytokines to the site of injury. And poor perfusion can either be due to peripheral arterial disease, like a diabetic with a non-healing foot ulcer, or venous insufficiency where there's blood pooling in the lower extremities. And another pathological form of wound healing is excess deposition of extracellular matrix. An excess of extracellular matrix can either form a hypertrophic scar or a keloid. A hypertrophic scar is one that is raised due to excess deposition of granulation tissue that then reepithelializes over the top, but a hypertrophic scar will stay within the confines of the original scar. It's essentially just raised. A hypertrophic scar can be surgically removed and will not grow back, whereas in contrast a keloid scar is a genetic predisposition that's seen in some African American populations due to excess of TGF-beta signaling. Keloid scars are when there's an excess extracellular matrix deposition, especially with type 3 collagen, and the scar tissue is very grossly overgrowing the original injury. It's not just raised, it actually expands beyond the original margins. Histologically, a keloid scar will show very thick bundles of collagen within the dermis that is highly disorganized. If a keloid scar is surgically removed, it will actually grow back and possibly even worse. And keloids can occur following even minor trauma, for example on the face, arms, or even the earlobes after an ear piercing, and just grow out of control. And then for a final topic I want to touch on is cutaneous wounds. It's very important to know one more special type of wound healing for the purposes of MBME exams. Cutaneous healing can either occur through a primary or secondary intention. Cutaneous wounds heal as the epithelium regenerates over the site of injury and the connective tissue fuses the edges of the cuts. Primary intention is a very special circumstance in the case of a surgical incision held with sutures. Surgical incisions cause minimal cell death, so that epithelial regeneration is the principal mechanism of repair. When the stitches hold a wound together, the edges are brought together very closely. The cut is then filled with a small fibrin clot, followed by the formation of very minimal amounts of granulation tissue. Finally, the epithelium grows over the surface as the adjacent basement membranes are brought together, resulting in very small amounts of scar tissue. Within the first 24 hours, inflammatory neutrophils migrate into the clot. Within the second day, up to 48 hours, epithelial cells are going to migrate over the clot while lying down basement membrane and ultimately meeting in the center. By day 3, the macrophages have replaced the neutrophils and granulation tissue is going to replace the fibrin clot. The epithelium continues to proliferate and granulation tissue peaks by day 5 and collagen bridges the incision. By 1 month, the scars have now been remodeled and there is no longer inflammatory infiltrate. The collagenous scar is covered by a regenerated epidermis over the top. Tensile strength of the scar will continue to increase until the end of the 3rd month. A key point to remember is that all dermal appendages are absent within the scar, albeit minimal. There will be no hair follicles, etc. And then in contrast, healing by secondary intention is when there is a much larger wound without the edges brought together, or in the cases of an abscess, an ulcer, or ischemic necrosis of internal organs. In secondary intention, there is much more inflammation and granulation tissue formed as it must fill in this gap. The more granulation tissue there is, the more fibroblasts there are, and ultimately the more wound contraction. Sometimes it's even 90 to 95% contracted compared to the original wound, forming a much larger scar. And then a final topic I want to touch on is wound strength. When talking about wounds healed by primary intent, a sutured wound will have about 70% of the strength of the normal skin due to the actual fibers of the sutures. Without the sutures, the wound would only have about 10% strength at 1 week. The strength will rapidly increase over the first 4 weeks as the granulation tissue accumulates and is cross-linked, and then the maximum strength of the scar will be about 70 to 80% of the initial strength, maxing out at about 3 months once the scar has matured.